My name is Deirdre Wheatley-Liss, and I'm going to be your host today. I am delighted to bring you this new installment of our Porzio Planning webinar series. Our mission with this is simple. A knowledgeable family is an empowered family. So every month we take the opportunity really to share with you the people that we gain knowledge from working with clients, so that, you know, I'm hoping that by the end of the hour, every single person who's listening will say, wow, I didn't know that about at least one thing. Now, this month's webinar is particularly timely because we are discussing Medicare. As Dan's going to share with you, the Medicare annual enrollment period begins October 15th and ends December 15th. So for anyone who actually is on Medicare right now, there's your window to be able to make some changes following the program today. If you aren't on Medicare right now, you're still going to learn a lot of good information about taking advantage of it. But before we get started today, I thought we might try to get a better sense of where our audience is in their Medicare journey. So Alex, if you can launch that poll, please. Excellent, thank you. So here's what I'd like to ask you to do. You or a loved one are currently receiving Medicare benefits, and we're doing this because we want to be able to tailor our comments today. You or a loved one are approaching Medicare and you just need to know more about it and how it works, or you have no idea how Medicare works and you're just trying to get a larger knowledge base. So while we give that a second to be able to run, I'm going to introduce myself as well as our guest today. So Alex, I know it takes time to close that out, so if you want to start that process. So just as an additional introduction for me, I'm an attorney. I'm a principal with the Wealth Preservation Group at Porzio. I'm the founder of Porzio Planning, which is a separate complimentary service that we offer that just gives the community information on estate planning, elder law, asset protection planning, and related litigation issues. Now, you may have a super great idea about what an estate planning attorney does or an elder law attorney does, but you may have no idea what a Medigap advisor is, much less who the Medigap advisor is. Dan, since you are the Medigap advisor, can you please introduce yourself to the audience and just share quickly, you know, how it is that you work with families to maximize Medicare benefits for their healthcare dollars?
Absolutely, Deirdre. Thank you for having me today. I think this format is great and really looking forward to working with you today. So just a little bit about my background. I've been in this field, I would say 15 plus years. The foundation of my practice and where I still work is in the life insurance, retirement planning, long-term care planning, and so forth. And as I was working with my clients interested in those areas, more and more and more questions were coming in about Medicare planning, healthcare and retirement, what to do, where to go, and when to do it. So I dug in more and more and really enjoyed helping my clients in this area, found it fascinating and fulfilling and a huge help. And from that was born the Medigap advisor. So we've been doing this for many years, helping our clients just navigate the Medicare process. So I would say it's from Medicare process from A to Z. It's really the Medicare process from A to D. And with that, we are a completely independent resource. We never charge our clients a fee. And one of the big things that we do, because this is such a personal process, is we work very closely with our clients and we build a long-term relationship with our clients. We are going to help them with whatever they're dealing with today, and we work to be their resource for the long term, 3 years down the road, 5 years down the road, 10 years down the road. And in following up what you had mentioned about the annual enrollment period, that's a perfect example. So annual enrollment period, October 15th through December 7th. This is for people who are already on Medicare and for people who want to make a change. We are going to talk to many, many, many of our friends and clients who are on Medicare and want to make a change. We'll speak to a lot of new people too, but for us, this time of year is going to be something similar to tax time for an accountant. And will be, it's through our connections, contacts, and the knowledge and the foundation we've built with our clients over the years that it makes it easier for us to work with them during the annual enrollment period, which is such an important time.
Excellent, Dan, thank you. So now that you know a little bit more about us, Alex, can you launch those poll results, please? Excellent. So when we're looking here, we have some of you currently on Medicare, many of you focusing on the idea of approaching Medicare and really how do you maximize those benefits, as well as those looking for some general information. So we'll certainly emphasize some of the things to think about as you're approaching Medicare. So Alex, if you can close that out. And before we go to the next slide, let me just remind you, this is really an all about you moment. Dan and I have lots of good information. We think it's super exciting information, but it may not be what you're looking for today. So please, if you move your mouse around on the screen, there's a Q&A button at the bottom. Please take advantage of that to ask us questions. We'll try to answer the questions in real time. We'll reserve some time at the end to answer questions. And if we don't get to you, we actually can answer them offline later, or if you're watching this as a recorded webinar. So Alex, can you flip to the next slide, please? So what are we going to talk about today? All right. First of all, as I'm sure you can get from Dan's introduction, he's just going to share with you the tip of the iceberg about what it is that he knows about Medicare. One of the reasons that we work closely together is that it's not an area that I, as an attorney, have extensive expertise in, but since healthcare costs are something that families have to address year after year after year, maximizing the benefits for those costs feeds directly into the estate planning and elder law planning advice that I'm then going to give to my clients. So we're going to start with what does Medicare cover, and very, very importantly, what does it not cover, and what things can you do about that? How Medigap policies work, supplemental policies, and as Dan alluded to, sort of right-sizing the coverage each year. So Dan, before we move on, can you just share this photo that we have here and why it is that when we're talking about Medicare, this is really the starting point?
This is the starting point. This is a favorite photo of mine, and have it hanging in my office. And this is from July 30th, 1965. When LBJ signed Medicare into law. So really, when you think about it, Medicare is not that old. Now, when I tell my kids about, Medicare and that it was signed into law in 1965 and what that might look like, they're like, yeah, we know what it looks like. And they start describing a scene from Hamilton with powdered wigs and quill pens, but it is not that long ago that Medicare was here. And it's very appropriate in this photo, for anybody who's a history buff, that Harry Truman was there for the signing. He was the champion of Medicare because in 1963, there were maybe half the people 65 and over who had any kind of insurance against a hospital stay. So previous to Medicare, seniors were basically fending for themselves. They were using savings. They were relying on family, charity, the hospital not charging. I mean, that was literally a strategy. And because of the push from Harry Truman, LBJ in 1965 signed Medicare into law. And Harry Truman actually is the first, he's Medicare recipient 001. He's the first. And since then, there's been more things happening in growth of Medicare, but it all started on that day.
Okay, thank you. Alex, if you can go to the next slide. So if you weren't thinking about, wow, what's the one thing I didn't know about Medicare, I guarantee you can now win trivia as to who has the first Medicare number. So here's a chart. If you've attended our other webinars, this chart might be somewhat familiar to you. We're talking today about how healthcare intersects with retirement and why is that important? Well, the vast majority of people start using Medicare at age 65, which is also when they're looking for retirement. But note here, in 1970, there's 20 million people utilizing Medicare services. Now there's 64 million people utilizing Medicare services, which is about 20% of the US population right now, scheduled to increase to about 86 million people. As I've shared over and over again, when you're thinking about how to make sure that your retirement looks the way that you want it to, you have to plan for the resources that are there as well as the resources that may not be there. Medicare puts a huge amount of pressure on the US budget every year, notwithstanding all the other pressures that have recently been on our budget. because it has been there doesn't mean it always will be. And to Dan's point, Medicare hasn't been around forever. It's a relatively recent item, you know, for a couple of generations, that this is something that they could count on in their retirement. So that's why we're really going to emphasize today not only what it does, but what it doesn't, and some planning that you can look for around what happens if Medicare isn't there for you today, tomorrow, the same way that it is today. So Dan, with that, there's often a popular question: will Medicare be there for me? And since you work in this space and obviously you study about it, will there be Medicare in the future, or maybe are we looking potentially at different versions of Medicare?
To answer the question directly, I do believe Medicare will be available to seniors in the future. And I will get back to that because I want to add in one more pressure on Medicare. And that is that not only is Medicare available to all citizens 65 and over, but since 1972, Medicare is also available to people who are under 65 and disabled. And at this point right now, of that total Medicare number, 16% of all Medicare recipients are actually under 65 and the qualification is receiving Social Security disability for 24 months. So that's another important and another lifesaver, but another pressure on Medicare. I do believe Medicare will be around in the future. Obviously, a huge political football. You have.
We don't touch political footballs here, so
yeah,
and somebody did ask a question, so I'm not.
So we're going to stay away from that, but we have. It has, you know. Here's one of the things that hopefully everyone who's making a decision on Medicare for seniors in the future. The fact, going back to, you know, the advent of Medicare in 1965, it's no coincidence that the life expectancy has been going up every year. So the correlation between Medicare and life expectancy, you know, we've had the science, we've had the research, but we didn't have the access. Now we do through Medicare. And when changes happen in the future, so this is my hope, that there may be changes in the future, but that our senior population is always thought of first when it comes to Medicare, and that they are protected and this system continues, because it gets really high marks from everyone who uses it. And that's Republican, Democrat, and Independent. And I've seen the numbers broken down exactly that way. And
okay.
You know, most people are very, very much in favor of Medicare.
So there was a question about whether you're still employed when you reach age 65, and we will get to that. So I just want to put a pin in that. I want to flip to the next slide now and really just move to the heart of the matter, okay? And again, we welcome your questions as we go through this. Dan, this is what I'd like you to talk about. Who qualifies for Medicare? And you already did some of that because it's not just age 65. Really, really importantly, what do the different parts of Medicare cover? And then before we turn from this slide, we're going to go through all the things that Medicare doesn't cover, some of which may be a surprise to our audience. So maybe you can start with the coverage question, because we already talked about the who's qualified.
Yeah, so we discussed that, you know, you know, the qualification, of course, is a U.S. citizen 65 or over, or someone who is on disability. And then just as further definition before we get into the ABCD, often asked about Medicare, is it a family plan? Is it a group plan? Medicare is absolutely an individual plan, person by person by person. And, you know, for us, when we're working with clients, we can work with a husband and wife and have different perspectives, different needs, different results, different plans. So Medicare is very individual. And one of the things it's not Medicaid, it's not Social Security, and again, it's not a family plan. So, you know, just some of the common questions.
A follow-up question, and I know we're going to talk about supplemental policies, but if I'm understanding what you're saying, then you might have a husband and wife, both over age 65, that come to you, and that the best plan for them might involve two entirely different utilizations of Part C and supplemental policies and things along those lines.
Exactly.
Excellent. Okay, well, I know we're going to get to that later, but I'd love to circle back to that. Okay, A, B, C, and really, could they have been more generic when they named all of these? Can you maybe go through a little bit about what they, what kind of coverage you get under Medicare from the outset?
Yes, and the alphabet is reused in other areas to make it even more overlapping and a little confusing. But these are the Part A's, to be distinguished from anything where it's a plan, some G or Plan F or Plan N. Part A and Part B, those are the government issued, standard government issued coverages that every person who's 65 and over and is a citizen of the US is entitled to. And this is what you enroll in through the government. So Part A and Part B, when you get the red, white, and blue card that most of my clients can't believe that they're getting because they always saw it in their parents' wallet, but they finally get their red, white, and blue Medicare card, it is going to have a Part A effective date and a Part B effective date. So Part A is hospital insurance. And so by that, what we're talking about is inpatient coverage for someone who has a hospital stay. So this is semi-private room and board, food, nurses, services, staff. It could be lab tests that are done in the hospital, drugs that are taken in the hospital. It will also cover hospice care, and it will also hit on something that is extremely important, which is skilled nursing care. If a Medicare beneficiary who's on Part A has an extended stay in the hospital, they then would be entitled to up to 100 days in a skilled nursing facility for rehab. Not always the easiest time for someone who's making that transition from the hospital, either back to home or maybe to another facility, an assisted living facility, a nursing home, or so forth, but a critically important aspect of Medicare coverage.
So let me just pause on that because I have to put my lawyer hat on that. So one of the
Sure.
I often run into with families is a loved one is in the hospital. They are summoned to a discharge meeting. They are asked to select where it is that the person's going to go, and they select to have the person go to rehab. And now they're in rehab, and they're like, it's covered by Medicare. Okay. And just to be clear, the first 20 days are going to be fully covered by Medicare, but after that, part of it's going to be covered, which is one issue. But the second issue is Medicare is medical insurance. It is not long-term care insurance. So you can end up in a situation where your loved one isn't progressing, for lack of a better word, and now they're in a facility that was maybe a good idea from a rehabilitation standpoint, but is not a good long-term solution. So, my takeaway on this is that if you do have a loved one that they're utilizing the rehabilitation services, there's a limited time frame, and you should be thinking during the rehab time frame, if the rehabilitation is not as successful as you want it to be, what is your plan B going to be? Because you're going to get about maybe 24 hours notice that Medicare is not going to pay for their stay anymore. They still aren't able to go home. And now what are you going to do? And that's not a decision that is made well in emergency circumstances. So that's my attorney piece. So Dan, let me flip it back over to you. So if that's Part A, let's look at Part B.
So Part B would be doctors, outpatient services. It will cover a long list of things. So Part B is going to cover your doctor in the hospital. So surgery that you might have in or out of the hospital is going to be covered under Part B. You're going to have physical therapy, all the therapy, speech therapy, diagnostic tests, MRIs, EKGs, durable medical equipment. which is very, very important for many of my clients, from anybody who has type 2 diabetes to, more serious ailments. Durable medical equipment becomes very important. Ambulances, just a long list of things are covered under Part B, but primarily think of it in terms of doctors and facilities and things really outside of the hospital.
Excellent. And then that leaves us with part, not plan, part C and D.
Part C and D. Now, A and B are provided by the government. They cover a lot, and we will talk in a few minutes about, things that Medicare does not cover, but they do cover a lot, but they don't cover everything. So Part C and Part D, when we go back to our history lessons, Part C and Part D are actually relatively new additions to the Medicare list. Part C is otherwise known as Medicare Advantage. And this was put into effect. This was signed by Bill Clinton, and trying to be, completely bipartisan. So Richard Nixon signed into law the ability for people under 65 to use Medicare. Bill Clinton, now we're going Republican, Democrat, back and forth. Everybody's really had has had a share in expanding Medicare. 1997, Medicare Advantage plans that were called Medicare Choice plans at the time, but Medicare Advantage plans came into being. And Medicare Advantage plans are provided by an insurance company. An insurance carrier will be where someone would sign up for and enroll in a Medicare plan. And that is all dependent upon where you live and many other factors. But Part C is Medicare Advantage, which would, I guess we could start talking a little bit about Advantage plans, but essentially, if you go into a Medicare Advantage plan, you will roll all your hospital, medical, and usually your drug plan will all roll into your Medicare Advantage plan. You'll have one card, and this would provide you with your coverage. You can think of it maybe as an Medicare HMO or PPO for those of you that are on group health plans and have an HMO or PPO. And Part D, which is Part D for drugs. And again, Part D is provided by insurance companies. And Part D was signed into law in 2003 by George Bush. And Part D is extremely important, critically important to our clients, probably the largest part of the conversation for many people. Many people are fortunate not to have more than one or two drugs, but there are many people who, again, the Part D conversation is so critically important. And this is going to be the key aspect of what we are going to be discussing with our clients during the annual enrollment period. Part D is provided for either in a standalone Part D prescription drug plan, or Part D can be provided for as a part of a Medicare Advantage plan. Those are the two areas where you get them. And when your drugs change, or if the formulary of your current drug carrier changes, then it may be time for you to make a change to save money and get better coverage.
So Dan, what exactly do you mean by if the formulary of your drug is, so I get if my drug changes, I was taking drug A and drug B. What do you mean by if the formulary of your Part D coverage provider insurance company changes?
So again, these are plans that are run by insurance companies, and they do have parameters and regulations, and they must carry all the categories of drugs necessary, as deemed by CMS. But there are different ways to cover things. There's brand drugs, there are generic drugs, there are combinations of drugs, step up, where start with 2 of one or 1 of one and you move into a different drug. The drug companies and their panelists of doctors can make decisions about the best way that they see to cover a particular category that is required to be covered. So a For years, Lipitor was the go-to drug for for many people with cholesterol issues, and all the carriers covered it, and it was reasonably priced. Well, atorvastatin came onto the scene once generics were allowed to be used, and now over the years, fewer and fewer Medicare Part D carriers were covering actual brand Lipitor, to the point where we are now, where they're only covering the generic. So carriers can make changes to their formulary, but they're still covering the categories necessary in the Part D. So they'll have different costs, different premiums, even different deductibles for their plans. They all have to be looked at total together, and then you have the final results as to what plan is going to work better for a particular person.
Yeah, and I think that that's very important, because this is actually how Dan and I got connected, as a client that had a situation where they were covered for something the year before, they weren't covered the next year. They said, well, I didn't change anything. My doctor didn't change my medication. But what happened is their coverage had changed. And quite frankly, they were totally unaware that, I mean, I'm sure they got things in the mail. They were not recognizing that they had an opportunity to potentially right-size their coverage. So again, one thing to take away today is that for people who are already on Medicare, for that percent of our population who's listening today, this is your time to make sure that for each of you personally, the Medicare prescription coverage that you have covers your specific situation, not whatever situation you had 7 years ago when you first went on Medicare, which quite frankly is what I often see, because people just don't realize that they can be as active in managing some of their healthcare coverage for what it is that they have. So with that, that's sort of one of those, those aha, unexpected gap areas. So Dan, we've talked a lot about what it is that Medicare covers, and it seems like it covers everything, but you and I know that that is absolutely not the case. So maybe we can start to go down through an idea of some of the key things that Medicare does not cover.
Got it. Well, when we're talking about Medicare, and as I said, when you get that Medicare card, it is going to say Part A and Part B. So when you have Medicare, your Medicare card, officially, I would still include prescription drugs as something that Medicare A and B does not cover. So you would need to get coverage somewhere else for your prescription drugs, as we had just discussed. There are also copays and deductibles associated with Part A and Part B that are not covered. And there is, particularly with Part B, there's a 20% gap in coverage for medical expenses associated with doctors and facilities. Then moving down the list, as you mentioned earlier, long-term care is not covered. Often people consider those 100 days in a skilled nursing facility as maybe a portion of long-term care, and it might be, but it is limited to just 100 days. Then we have
let me just speak on the long-term care issues. So there is a question that came up. So what if I need a nurse to visit me once a week for wound coverage or something along those lines?
Nurses are not considered, nursing is really not long-term care. Long-term care would be custodial care. Those 100 days of rehab, in there, what the purpose of that is really just to get you back to neutral after your hospital stay, after you're done with your medical treatments, to try and get you to a point where you can then leave the facility and either go home or go somewhere else. It's often a transition period. So a nurse is not really considered a long-term care custodian. It's don't want to get too in depth on long-term care, but that's really just your activities of daily living. It's a different thing. It's not medical care per se.
Right. So it's a bit of a leading question, because there was a question about whether or not they'll pay for home health care, and Medicare does not cover home health care. Home health care being assistance with activities of daily living. I need somebody to help me get out of bed in the morning. I need somebody to direct my medication. I need somebody to help me get dressed. I need somebody to help me when I'm eating. Medicare doesn't cover any of that in any way, shape, or form whatsoever. However, I think there is confusion because they do cover skilled care visits to the home. Again, the nurse who's dealing with a wound care issue, but
Yes.
that's not custodial care. So, and honestly, it's a topic for a whole new conversation, but the takeaway there is that if you're looking as a way to pay for long-term care insurance, to pay for long-term care other than utilizing your own assets, you're really looking at long-term care insurance, or you're looking at doing some kind of asset protection planning to minimize the amount of assets that are available for long-term care payments. But that's not the only surprising thing. I'm going to say that's the most expensive thing probably that Medicare doesn't cover. But there's a lot of actually medically related things that it doesn't cover. So let's talk about dental care.
Correct. Dental care, your routine dental care is not covered. So it's most dental care. I mean, if you had a dental issue that was taken care of in the hospital, that could be covered. Doesn't sound pleasant, but for the most part, what you think of as, dental care, that is not going to be covered. Routine vision, glasses and contact lenses and so forth. I mean, people always ask, it's like, I see vision is not covered. What about glaucoma? What about, cataracts? Those are medically necessary issues. So those will be covered. Those are, glaucoma and cataracts, of course, for our Medicare population is a huge issue. But prescription glasses, they won't be. Hearing aids, that is when you're talking purely Medicare, A and B, hearing aids and the fitting of hearing aids are not covered. Dentures, of course, cosmetic surgery, routine foot care, and then acupuncture, although Medicare is now covering acupuncture specifically for chronic back issues. That's it. That's the only exception. And then this is probably too much. There's something called an excess charge. It's probably too much detail for this, but just that's one of the other things that I include as uncovered by Part A and Part B Medicare.
All right, so before we look at how do we solve some of these gaps, which is going to be our next slide, what happens if I'm on Medicare and I am in Rome and I get sick?
Thank you for bringing out the one thing that I did leave off the list. Yes, very perceptive. Yes, travel outside of the US is not covered by Medicare. Medicare is primary when you have A and B is fantastic around the US. But once you step back, Medicare stops at the borders. And so, yes, that is a really big consideration for Medicare. So thank you, Deirdre, for helping me with my list.
In years other than 2020, people actually did leave the country. So I just wanted to make sure that our audience was aware of that.
We used to get that question all the time. I'm leaving the country. What do I do? Now, not that often. I'm leaving our house. What do I do?
So, so a lot of the gaps, though, there's these Medicare supplement and Medicare Advantage. So potentially a number of the gaps that we address, not long-term care, but a number of the other gaps that we addressed can potentially be covered through this. So you shared with us sort of how it is that the Medicare Advantage plans work. So can you talk about the supplement and sort of the thought process between those options?
Yes. And just to begin with, we work with people really around the country. And there are some aspects of Medicare supplement that is standardized. But what is available to you as far as supplement plans and certainly Advantage plans and drug plans really depends on where you live. And the decisions are going to be based on your needs, your budget, your doctors, where you're living now, where you're moving later, your long-term plans. All of this comes into play. Again, making this even more of an individual decision. The big conversation that we have, and what Medicare Supplement and Medicare Advantage plans are going to do, are going to address some of the most important aspects of the healthcare, which is really the co-pays, the deductibles, the 20% gap, the prescription drugs. Those are the primary things that we're addressing with these plans. And when you're looking at a Medicare Supplement plan, what we have in that scenario, as you can see, Medicare is actually your primary insurance when you have a Medicare Supplement plan. It's Medicare A and B, primary insurance. You're seeing doctors who accept Medicare, and you would use your supplement plan to pick up the expenses or pay some or all of the expenses that Medicare does not pay. When you are looking at a Medicare Advantage plan, as I had mentioned earlier when we were talking about Part C, which is what Medicare Advantage is, a Medicare Advantage plan is managed by, is enrolled through an insurance company, whatever that insurance company is. And so with that, you have the one card, and you will have hospital, medical, and generally drugs covered in that plan. And that would be your primary insurance. So you need to make sure that whatever doctor you're seeing or any new doctors that you're going to see accepts the plan, the Medicare Advantage plan that you are enrolled in.
So as an example, so let's say it's Blue Cross Blue Shield, right? You would have to make sure that the doctor that you see takes Blue Cross Blue Shield Medicare Advantage. I just want to see if I'm clear on looking at this.
Yes. And again, with this, I actually, that card, because we're primarily in New Jersey, I do something that's not even around here, just totally, but yes, you want to make sure that your particular carrier is accepted by your doctor, and you really want to get very fine on this. You want to say, okay, I'm on, this insurance company, Medicare Advantage Plan 5. And you want to make sure that your doctor takes Plan 5. She may take Plan 1, 2, and 3. And you want to make, this is something we take so seriously. We check, our clients check, we check again. Very important, even with Medicare, because
so again, we're in this annual enrollment period right now. So is this the kind of thing that also potentially changes from year to year? My physician was accepting this plan now, and now my physician is no longer accepting this plan. So if I stay with the current plan, I'm going to have to then change doctors. Is that sort of a result that can commonly occur?
Absolutely. Absolutely. So with that, it's if there is a doctor who, exactly as you described, that's an important scenario, and this is the time of year when we can make a change for a client who's on a plan where a doctor that they must or want to stay with may be on a different plan or have dropped the plan that they were on. This is the time to change into that other plan, and so that they can continue to see the doctor.
So we got sort of a high level question that I think, probably a lot of people are having. So why choose one versus the other? Why go with Medicare Advantage and the one card versus a Medicare Supplement and the 3 cards?
So there are a couple of key factors. As with anything, it always comes down to cost. Budgets are key. So when you're looking at a Medicare Supplement plan, one of the big advantages is that you can see any doctor that takes Medicare across the country. That's not every doctor, but it's the majority of doctors. And so that's a big plus. But when you're using the supplement plan, it will generally have a higher premium than a Medicare Advantage plan. And so there's no referrals necessary when you're working with a Medicare Supplement plan, but there's also really no other add-ons, some of the things that we did discuss, like hearing and dental, none of that. Medicare is primary, so whatever Medicare doesn't cover, the supplement doesn't cover. And further, you do need to have a standalone prescription drug plan, which will have another premium. So in most cases, the premiums for supplement and drug plans coupled with your Medicare plan could provide very comprehensive coverage, but it will have higher premiums. And, that's a big consideration. Medicare Advantage plans generally have can have extremely low premiums. But with that, there are co-payments that you won't experience when you use Medicare with a supplement plan. So there is always a menu of co-payments with a Medicare Advantage plan, and they are going to vary because really there are many different Medicare Advantage plan options, and this is throughout the country, and different carriers and different plans and different things that they offer. And the other thing that's incredibly important is, the network. There are some plans that are HMOs, so you really have to be in the particular Medicare Advantage networks. Others have a greater expanse. Some have national coverage. It's plan by plan by plan. And then there are some other added benefits. There could be a fitness program. There could be some dental. There could be some vision. There could be money towards hearing aids. It all depends on the plan, and it depends on the person that we're working with as to what is the best option. And it generally comes clear fairly, the decision is generally pretty clear for the vast majority of people that we work with after a pretty detailed conversation.
Okay. No, and I think again, the takeaway here is, Dan, you just shared so much, 400 different options and how it is that you put them all together, is that people have a way of choosing what their coverage is going to look like, but they have to engage in the planning for it. And as everybody knows, I'm focused on people doing planning, but unlike other kinds of planning, you got a limited window to do this one because this is the annual enrollment period. Just moving to the next slide, annual enrollment is not the only enrollment. So we did have a group of people that are approaching Medicare,
Yes.
and how it is that works, and particularly if you're employed versus you're not employed at age 65, if you could give us some detail on that.
Yeah, so Deirdre, to your interest in having an important takeaway, I would say that what we're going to discuss right now is a very important takeaway. So for people that are approaching 65 or have a loved one that's approaching 65 and are working, there are different rules about enrollment for people that work in companies with more than 20 employees or less than 20 employees. So, and in that, what we'll say is people who, it would also be somebody who's self-employed, unemployed, retired, that would be lumped in. But for people who are working in a small company, less than 20 people, when they turn 65, they do need to enroll in Medicare A and B. If you are working for a large company with more than 20 employees, you have the option to either enroll in Medicare A and B, or you can continue on the group health plan, keep that as your primary insurance for as long as it's available to you, let's say until you retire. And then when you retire, because you were on a group health plan, the time that you were, from the time you were Medicare eligible, you would then be entitled to a special enrollment period. So no penalties, no delays, but that would be a special enrollment period that would occur based on the fact that you were on a group health plan with a larger company while you were Medicare eligible. And this also applies if you are on a spouse's plan. So if you're on a spouse's plan and they are working for a large company, same things apply. But if they're working for a small company and you're on their plan, you have to adhere to the same under 20 rules.
Excellent. Okay. So I'm thinking there are a lot of people out there that had absolutely no clue about that. When does the government get around to telling you this? Let's say in terms of, hey, you're going to be turning 65. Like, what kind of communications can people expect?
If you are collecting Social Security in advance of your Medicare eligibility, because you can start collecting Social Security as early as age 62. If you are collecting Social Security, you will automatically be enrolled in Part A and Part B, and be sent a Medicare card in advance of your birth month. From there, you need to decide if you're going to keep your Medicare, or maybe then suspend your Part B, keep your Part A, suspend your Part B, based on the group health plan that you are on yourself, through your own company or through your spouse's company.
Gotcha.
Otherwise, you just have to be aware that you are coming up on age 65, and that there are some decisions that have to be made.
Okay, so you see why you need some help in doing this. So, when you're making the decision, a lot of it seems to be about cost, particularly if I'm at a company, I'm still working, and I'm over, there's more than 20 people. If you can flip to the next slide, Alex, I gotta say, Medicare's cheap. It really is for any of us who are paying our private premiums right now, who do not have the ability to take advantage of Medicare. But it certainly isn't free, and the amount of cost, and this is just on your Medicare premiums, that you're going to be looking at is going to vary based on sort of who you are. So Dan, and again, this is separate from the supplemental policies, but can you give an idea for the sort of the base policy about what it is that people are looking at from an out-of-pocket cost?
Well, yes. And so with this, this came out of Obamacare. So the fact that they decided now to charge different premiums, the A and B, same benefits, but the premiums are going to be different for people with higher incomes. So this is based on your household modified adjusted gross income averaged out over the past 2 years. So even if you have a spouse that's not Medicare eligible, it will still be the household income. And those people who have higher incomes will be charged an income related adjustment amount. They call it IRMA, and get lots and lots and lots of calls about IRMA. And so the bottom line is, if you have a modified adjusted gross income, if you're going into Medicare now, they're going to be looking back at 2018. And if you had a modified adjusted gross income as a single filer of 87,000 or below, or a joint tax return of 174,000 or below, you will pay the base rate of $144.60 a month per person, always individual. As the income increases, so does the charge. So as you can see in the next category, 87 to 109 for the single filer, or 174 to 218 for the joint filer, there's going to be a $57.80 IRMA on the Part B premium. And then there's actually an IRMA on Part D, which the Part D, as we know, is purchased through an insurance carrier company. But when you get that in that Part D plan, you will be assessed the $12.20 IRMA charge. That will be the 202.40 and the 12.20 will be added together, and you will either send that to the government or it will be withdrawn from your Social Security benefit check, which is how Medicare Part B is collected.
Excellent. So, what I'm really, because, the first part, you're like, how do you design coverage? And then the second part is, what is sort of what your budget's going to look like around it. And these are obviously all things that people need to be looking at as you're looking at what is the cost of my medical care going to be in retirement. If you can flip to the next slide, please. As I said, there are gaps in where the coverage is. So I just want to talk a little bit on some of sort of the legal planning that you can do if we're looking at healthcare in retirement. The first is to have a living will. A living will is a written intention of, if I'm in a terminal medical condition, this is what I want to have happen. The single most important thing to do with a living will after signing it is to please have a conversation with your family members about what kind of care you would want in a terminal medical condition. Regardless of how it is that it's being paid for, this is a decision that you're allowed to make, and I encourage you to exercise your rights to do that. The second is having a medical power of attorney that has a HIPAA authorization in it. So a medical power of attorney, which can be in the same document as the living will, is going to say, you, my daughter, have the ability to make decisions for me for my medical care and treatment that I may need. Because I have a HIPAA authorization in it, you are allowed to receive my personal private medical information to inform you in making those decisions. And my one practical tip on the medical power of attorney, this is somebody who may have to act somewhat quickly under relatively dire circumstances. I don't know if people often give a lot of thought to it. I'm going to name my oldest child because they're my oldest child. Your oldest child lives in California. Your second child is a nurse who lives in Pennsylvania. Maybe you want to think about having your son who's a nurse in Pennsylvania as opposed to your daughter in California acting for you. Just be thoughtful about it, because this person's going to have to make some real decisions, and with some of them, the ability of proximity will make decision making easier. Another one in New Jersey is a post form, and this gets into the ideas if somebody has a terminal medical condition. In New Jersey, a post form, physician's orders for life-sustaining treatment, and you'll know if you have one because it comes out on like an acid green piece of paper, are basically medical orders that you can take with you. So if you've had a discussion with your physician and say, this is the course of treatment that I want, and you end up having an episode and end up in the hospital, the resident's not diagnosing what your problem is. You're sharing with the resident, these are my post orders, and then they're carrying out what you and your primary physician who knows you well have actually put together as a plan of action. And the last one I want to mention is in New Jersey, they recently passed a law dealing with the right of dying. And I think, unfortunately, it's highly misunderstood. I often get the question of, or the statement, the throwaway statement, well, when I have Alzheimer's, I'm just going to go at that point in time. I can do that. I'm in New Jersey. That's not actually how the law works in New Jersey. The way that this law works in New Jersey is that an individual who wishes to take advantage of it must have both mental capacity and physical capacity at the time that they choose to carry out the act. This is not somebody else doing you in. That's called homicide, not the right to dying in New Jersey. This is instead a situation where you may have a terminal disease. It may be important to you to control what your path looks like. As long as you can meet the mental criteria that you are of clear mind and that you have the physical capacity to engage in whatever that act is, that is how you take advantage of it. If that is not something that you wish to take advantage of, you don't have to worry about it, but I want you to know, again, as part of sort of our service to the community, that it's something that's out there when we're looking at the idea of healthcare around aging issues. So we've gotten a lot of great questions. We've got about 5 minutes left. Actually, we've probably got 3 minutes left for questions right now before we close everything down. And one of them that I wanted to look at is, so quick one off the top. Can you get a Medicare supplement plan that covers overseas?
There are supplement plans that do have a lifetime coverage. Generally, it's 80% of the first $50,000 of overseas. And that's it. That's the max out. And it sounds like a lot, but I still recommend, added coverage beyond that because it can go fast if there's something serious.
Excellent. Now, and this is going to be an important question in this situation because unfortunately many people are not as fully employed as they were in March of this year. If you're on COBRA from a company with over 20 people, would you potentially have to then sign up? Are you now unemployed? You are on COBRA? I don't know if you know that answer off the top of your head, but I wanted to post that to you.
I think that is a fantastic question and another important takeaway. When you are Medicare eligible, COBRA cannot be primary. And this has caused problems for, more than a few people when it comes to Medicare. People who, let's say, retire when they're 64 or furloughed or lose a job and then turn 65. Medicare has to be primary to COBRA. So whether it's over 20, under 20, if you are Medicare eligible and you lose your group health coverage, you then want to sign up for Medicare Part A and Part B.
So
and we
another
didn't even
question.
get into the, go ahead.
Yeah. So another question, again, I'm sort of trying to do a lightning round and get as many of the questions in, and please keep them coming, as we're going through this. Is for a Medicare supplement plan, not Medicare Advantage, for a Medicare supplement plan, is there any like underwriting requirement? Do the insurance companies have an opportunity to deny individuals, maybe somebody who had cancer 5 years ago or something along those lines?
So when you turn 65 and your Part B begins, Part B start date creates a 6-month open enrollment for Medicare supplement. So at that time, you come onto a Medicare supplement plan, there will be no medical questions asked. If 2 years down the road, you wanted to make a change to your Medicare supplement, you could be asked medical questions. And also, this can vary a bit by state as well as to the rules on guaranteed issue or non-guaranteed issue Medicare supplement plans. But I would say in general, for purposes with like 10 seconds left to discuss, I would keep in mind that in most states, you will be asked medical questions if you change your Medicare supplement down the road.
Okay, so I just want to emphasize, because the majority of our audience today was people who are approaching Medicare age. And I think that was one of the most important things that you just shared with us, is that if you do or a loved one has a pre-existing medical condition, you basically get a free pass on initial enrollment, but after that, you may not get the coverage that you want and need. That's what I'm hearing you say, Dan.
Yeah, so that's a guarantee. Yeah, so turning 65 is a guaranteed issue situation for supplement, or when you have a special enrollment, you worked at your company for another 5 years, you're age 70, you're retiring from your company that had over 20 employees, you have a special enrollment and go through the process of getting that done, that will also create a guaranteed issue period for Medicare supplement, drug plans, and so forth.
Excellent.
Outside of that, it's different. The annual enrollment period really pertains to drug plans and Medicare Advantage plans as far as no medical questions.
Gotcha.
And really, I am generalizing because it's different by state, and as a lawyer, I'm getting to as many as I
disclaimers. So
yes.
So Dan, thank you so much for sharing your knowledge today. I mean, as you can see, when I said he's literally giving you the tip of the iceberg, and we're from the Northeast, we talk pretty quickly. There's what my key takeaway that I'm hoping, well, first of all, I hope every single one of you had a wow, I didn't know that moment. Secondly, my key takeaway is really getting back to the idea of the planning, that you can have a lot of control over what your healthcare looks like to match the coverage to your lifestyle. But there are certain dates by which you do not do things that you're going to lose options, right? And since we're here all about planning, one of the questions that was asked, how do I compare A and B? How do I put everything together? Dan's information is there. He has a ton of resources available on his website. I would encourage you to look at those. I know, unfortunately, we were not able to get to a number of the questions. To the extent that they are Dan questions, we're actually going to forward them to him so he can have an opportunity to sort of speak to you directly. If you have more, type them in quickly. And again, he is absolutely passionate about this, in case you didn't figure that out. In terms of resources on other items, please use Porzio Planning as a resource. And here's my ask for you. This is really important for us to be able to serve our community. It really is our mission to empower families through education to be able to make better decisions. If there is any topic that you would be interested in spending 60 minutes learning more about while you're having your lunch one day, or doing a replay as you're driving your car, from point A to point B, please let us know what they are. As attorneys, we become better because of the professionals like Dan that we surround ourselves with. And if there are questions that you want to know, we would love to bring somebody in to talk about it. So that, Dan, with that, I want to say thank you so very much for joining us
Thank you
today.
for having me.
It's been a pleasure. You're so knowledgeable and I appreciate it. And we are at the top of the hour. And since I do promise that every webinar ends on time, we're going to say goodbye and we'll see you next month. Thank you very much.
Be safe.